The importance of genetics in pancreatic cancer. Hello, this evidence-based content is prepared by Saboor, fellowship-trained consultant surgeon, and if you or someone you care about has been diagnosed with pancreatic cancer, or you're trying to understand what drives this disease at the molecular level, you're in the right place. I know hearing about genetic mutations and molecular pathways can feel overwhelming, but understanding these mechanisms is crucial because they're revolutionizing how we treat pancreatic cancer. Before we explore specific genes, let's establish what we mean by the molecular basis of pancreatic cancer. Pancreatic cancer doesn't just happen randomly. It's fundamentally a disease caused by specific mutations in cancer-associated genes. When we sequence the genetic code of pancreatic cancer cells, we find that multiple combinations of molecular alterations work together to transform normal pancreatic cells into cancer. The KRAS gene is the single most important genetic player in pancreatic cancer. Located on chromosome 12, over 90% of pancreatic cancers harbor a mutation in this gene. Let me put that into perspective. That's essentially universal. The KRAS gene is what we call an oncogene, a gene that when mutated drives cancer formation. KRAS mutations appear very early in pancreatic cancer development. They're found in non-invasive precursor lesions called pancreatic intraepithelial neoplasia, or PANN for short, which are microscopic changes that can occur years before invasive cancer develops. They're also present in other precursor lesions like intraductal papillary mucinous neoplasms, IPMNs, and the prevalence increases with increasing degrees of abnormality in these lesions. Here's where it gets interesting for treatment. KRAS was once thought to be undruggable, but targeted therapies are now available for specific KRAS mutations. If your tumor has a KRAS G12C mutation, present in a subset of pancreatic cancers, drugs like sotorasib and adagrasib can specifically target this alteration, with response rates of 21 to 33% in treatment-refractory disease. While KRAS acts like a stuck accelerator, tumor suppressor genes are like the brakes on cell growth. When they're inactivated through mutations, cells lose critical safety mechanisms. The three most important tumor suppressor genes in pancreatic cancer are TP53P16, also called CDKN2A, and SMAD4. TP53, the guardian of the genome, is inactivated in 50 to 75% of pancreatic cancers. This gene normally stops cells from dividing when DNA is damaged, and can trigger cell death if damage is too severe. When TP53 is lost, cells with genetic damage can continue dividing unchecked. P16, CDKN2A, located on chromosome 9p, is inactivated in over 95% of pancreatic cancers. That's even more common than TP53. This gene normally regulates the cell division cycle, and its loss removes another critical brake on cancer cell growth. SMAD4, also known as DPC4, is inactivated in approximately 50% of pancreatic cancers. This gene is part of the transforming growth factor beta signaling pathway, which controls cell growth and differentiation. But here's something that might surprise you. SMAD4 loss has important clinical implications beyond just driving cancer. Careful genetic analyses have established a progression model for pancreatic cancer. KRAS mutations appear first in the lowest grade precursor lesions PANIN1. As these lesions progress, P16CDKN2A alterations start appearing in intermediate lesions PANIN2. SMAD4 and TP53 inactivation doesn't appear until high-grade PANN3 or perhaps even later in invasive carcinomas. If you're supporting someone through pancreatic cancer, this section is particularly important because it directly impacts treatment options. Alterations in genes that repair DNA damage create specific vulnerabilities we can exploit therapeutically. BRCA1, BRCA2, and PALB2, known as core homologous repair deficiency genes, are present in approximately 3 to 5% of patients with pancreatic cancer. Here's the actionable part. National Comprehensive Cancer Network guidelines now recommend universal germline testing for all patients diagnosed with pancreatic cancer regardless of family history. If testing reveals BRCA1, BRCA2, or PALB2 mutations, patients can benefit from platinum-based chemotherapy followed by maintenance therapy with PARP inhibitors, drugs that specifically target cells with DNA repair deficiencies. DNA mismatch repair genes are mutated in approximately 2 to 3% of pancreatic cancers. Some of these cancers have a distinctive medullary appearance under the microscope. If you're supporting someone through this diagnosis, here's what matters most. These tumors may respond to immunotherapy drugs that don't work well in most pancreatic cancers. An estimated 10 to 15% of pancreatic cancers are attributable to genetic causes. If you have a family history of pancreatic cancer, particularly if you're worried about someone you love, understanding hereditary factors is crucial. Some genetic mutations dramatically increase risk. Peutz-Jeghers syndrome and CDKN2AP16 mutations can increase lifetime risk substantially. Hereditary pancreatitis associated with PRCS1 mutations increases risk, and this risk is particularly high in those who also smoke. BRCA2 mutations increase risk 3.5 to 10-fold, making this one of the most important causes of familial pancreatic cancer clustering. If you already have risk factors in your family screening programs using endoscopic ultrasound and MR, I can detect early precursor lesions at a potentially curable stage. Studies from high-risk screening programs show that 83% of cancers detected were resectable, with 12 being stage 1 tumors compared to the general population, where only 15 to 20% are potentially resectable at diagnosis. If you've been diagnosed with pancreatic cancer, request comprehensive genetic testing, both germline inherited and somatic tumor testing. Specifically ask your oncologist about next-generation sequencing panels that test for KRAS mutations, BRCA1, 2, PALB2, DNA mismatch repair genes, and other actionable alterations. Don't wait for genetic results to start treatment, but know that results may allow you to switch to targeted therapy. If you have family history, document your family history of pancreatic cancer and other cancers across at least 3 generations. Calculate your risk using tools like PancPro or BRCA PANCPRO, which are available through genetic counseling services. For patients with pancreatic cancer, ask, "My tumor tested positive for specific mutation. What targeted therapy options does this open up? Should I be referred to a clinical trial based on my molecular profile? Do my genetic test results mean my family members should be tested? For BRCA1-2 or PALB2 mutations, am I a candidate for platinum-based chemotherapy followed by PARP inhibitor maintenance therapy? For KRAS G12C mutations, should I consider targeted KRAS inhibitors like sotorasib or adagrasib? For DNA mismatch repair deficiency, could immunotherapy be an option for me? For those with family history, given my family history, do I meet criteria for pancreatic cancer screening? Should I undergo genetic testing even without a pancreatic cancer diagnosis? Seek referral to a high-risk pancreatic cancer screening program if you have Peutz-Jeghers syndrome, CDKN2AP16 mutations, or hereditary pancreatitis with PRCS1 mutations, regardless of family history. Have BRCA2 mutations with at least one affected first-degree relative. Have BRCA1 PALB2 ATM or Lynch syndrome mutations with one or more affected first-degree relatives. Seek urgent evaluation within 2 weeks if you develop new-onset diabetes after age 50, particularly with unexplained weight loss. Persistent abdominal or back pain with no clear cause. Jaundice, yellowing of skin or eyes. Let me quickly recap. Pancreatic cancer is fundamentally a disease driven by specific genetic mutations, with KRAS mutations present in over 90% of cases, representing the earliest and most universal alteration. Your next step, if you've been diagnosed, ensure both germline and tumor genetic testing are completed to identify potentially targetable mutations. This information is for education. Always discuss your individual situation with your healthcare provider. I have outlined several reputable resources here, which you may find valuable for further information on this topic. National Comprehensive Cancer Network, NCCN Guidelines for Pancreatic Adenocarcinoma, International Cancer of the Pancreas Screening, CAPS Consortium Guidelines, American Society of Clinical Oncology, ASCO Clinical Practice Guidelines, National Cancer Institute, Pancreatic Cancer Information, Pancreatic Cancer Action Network, PanCan-Lustgarten Foundation for Pancreatic Cancer Research. All links are available in the description below. Thank you for watching.